Right on. So let's go ahead and begin urology and nephrology. So here's a really fun image. That's a CT scan that's showing some staghorn kidney stones. We're going to talk about the different types of nephrolithiasis a little bit later today. But staghorn kidney stones are like the worst ones. They're huge. So they're staghorn. They look like little antlers. You have basically the renal, the minor and major calyces are going to be taken up by the stones. These things need to be surgically removed, right? They cannot pass on their own. So they usually require surgical intervention. So pretty scary situation when it comes to staghorn kidney stones. Generally secondary to UTIs, specifically Proteus mirabilis infections. Those are the ones that predispose an individual to developing staghorn kidney stones. So pretty nasty. And then you can also do like a percutaneous nephrothalotomy. It's a mouthful. That's kind of the way that they treat that. So it's a surgical intervention. Percutaneous makes it less invasive, but invasive nonetheless. So these are all the different things that we're going to be covering in nephrology and urology. Some stuff that you're going to see very, very often when you guys are out there in clinical practice. Like UTIs are extremely common. Other diseases, thankfully, not as common. So when we start talking about like nephrotic syndrome, things like that, post-infectious glomerulonephritis, those are going to be pretty rare in comparison. But UTI, extremely common. So we'll talk about all that stuff later. Now, for some basic labs, these are the basic tests that you can run in a lab. So you can do BUN, creatinine. Those are going to be gold standard tests to check if the patient has azotemia, things like that. GFR is going to be your glomerular filtration rate. That's how much your kidneys are actually filtering out, right? GFR is going to be a really good indicator for a person who might be entering into different stages of renal failure. As your GFR drops further and further, and you're starting to get into like stage 4 renal failure, at that point, that's when you're going to have to go into dialysis. We're going to talk about dialysis later on. You can also, of course, check for sodium, potassium levels. Like, for example, aldosterone is going to be one of the major things that affects these levels in the kidney. A patient with renal failure is going to have issues with vitamin D because remember, vitamin D in its active form is going to be synthesized or activated within the kidneys to allow for calcium absorption. You want to check for albumin levels because nephrotic syndrome, especially, you lose a lot of proteins in the urine. So you get proteinuria, albuminuria, and your albumin levels, because of that, you're going to lose albumin. So your serum levels of albumin drop and you get some like swelling as a consequence. You can check for red blood cells in the urine test as well. Ins and outs, right? So fluids ins, fluids out. So you can check for urine output. Again, urine tests, you can look for proteins. And then casts. Casts, there's going to be multiple different type of casts, and you guys are not responsible for that, except for muddy brown casts, which we're going to talk about later when it comes to tubular necrosis. But casts are going to be something that you find in the urine, depending on the situation. So you can have different types of casts, like hyaline casts, waxy casts, casts with hemoglobin, casts with leukocytes in it. Again, I'm not going to test you on the different types of urinary casts, but this is what we're talking about. These casts are going to be in the shape of like the nephrons. And so the different types of casts are going to be associated with different types of diseases. Azotemia. This is when you have an elevated BUN or creatinine. Actually, wait, hold on a second. Before we go into that, let's play a little video on BUN and creatinine.
I think it's safe to assume most everyone is aware of the fact that their kidneys produce urine. They do this by filtering toxins away from blood and excreting them into the urine. But your kidneys do so much more than that. They ensure that your body doesn't become too acidic or too basic, either of which could kill you. They produce a hormone called erythropoietin that allows for the production of red blood cells.
Okay, let me fast forward this.
Blood tests can determine the level of BUN, or blood urea nitrogen, in your body as an important indicator of liver and more so kidney health. The normal range of BUN found in the blood is approximately 8 milligrams per deciliter to 18 milligrams per deciliter. Every laboratory that measures these values may have slightly higher or lower ranges, but that's something I don't want you to concern yourself with right now. Instead, I'd like to get you to understand what abnormally elevated or decreased levels of BUN signal to a doctor. I recently told you that urea is made in the liver. The liver is like a factory that produces a product, urea. In order for a factory to produce something you'll agree with me needs healthy workers and raw material with which to produce their goods. If the liver is our factory, but the liver cells, the factory workers, are sick, then production drops. Therefore, severe liver disease or liver failure causes BUN to be lower than normal. Furthermore, if there's malnutrition, then the liver has little raw material to convert into urea, thereby also abnormally decreasing the levels of BUN. On the other hand, higher than normal BUN levels are a big indicator of the fact that something is impairing the excretion of adequate amounts of BUN. We already know urea is excreted in the kidneys, so it's no shocker that elevated levels of BUN point to this. However, the cause of impaired excretion doesn't always have to be the kidney's direct fault. For instance, congestive heart failure impairs proper blood volume delivery to the kidneys. The kidneys then think that the body has a low blood volume, which may not necessarily be true. In order to make up for this effective or in effect blood volume depletion as a result of heart failure, the kidneys reabsorb as much water back into circulation as possible. This, for reasons beyond this lesson, also causes more urea to be reabsorbed back into circulation as well, causing a rise in BUN. When the kidneys don't get enough blood delivered to them for filtration, we term this pre-renal failure. Pre-renal failure can occur as a result of any cause of low blood volume, aka hypovolemia, or it may occur due to effective volume depletion, causing improper perfusion of the kidneys in a normal bulimic person in cases such as congestive heart failure. What this really means is that while there may be enough or even more than enough fluid in our vasculature, it's not getting to our kidneys anyways, in effect causing a quasi-hypovolemic state from the kidney's perspective.
All right, we're going to talk about pre-renal, intrarenal, and post-renal failure a little bit later on, but effectively BUN is going to be one of the measures of whether or not your kidney is working. And so there's going to be different ratios, BUN to creatinine ratio that we can test to see if you have pre-renal failure, post-renal failure, etc. So if you want to watch the rest of that video with the guy's super annoying narrator voice, feel free to do so. But since it's 8 minutes long and I don't want to hear that guy's voice anymore, let's go ahead and continue. So azotemia, that's going to be high BUN or creatinine. Intrarenal, you're going to have a higher ratio of creatinine. Pre-renal and post-renal failure, you're going to have a higher ratio of BUN. Uremia is when you have azotemia plus other symptoms. So that's one thing that, remember going back to metabolic acidosis and acid-base imbalances, do you guys remember mud piles, that mnemonic? Right, it was like methanol, that's uremia. Right, that's going to be one of the causes of a high anion gap metabolic acidosis. So the other ones were like, DKA, ethanol, aspirin, all those things can cause high anion gap acidosis. But anyways, uremia is going to be one of those things. Oliguria is a term for a person who has reduction in their urinary output, and if it's really bad, it turns into anuria, right? So that's a person who's not really producing urine whatsoever. So this person right here absolutely would have to go into dialysis because they're going to start, there's all these nitrogenous wastes and all these other things are going to start accumulating within their blood, becoming super toxic. If a person has acute renal failure, that's referred to as ARF, also known as AKI, acute kidney injury, also referred to as acute renal insufficiency. Those are all referring to the same exact thing. Chronic renal failure, CRF, is also the same thing as CKD, chronic kidney disease. So those are all terminology, things that you should be familiar with in terms of terminology. Urinalysis is one of the easiest tests that you can do in the lab. In my Bio360 lab, It's medical physiology. It's for the BME, biomedical engineering students. That was our last lab. We did a urine analysis. And with urine analysis, you can find all sorts of different things that might be going on. You could see if there's an elevation in leukocyte esterase, which might indicate a UTI. You could see presence of white blood cells, right? Leukocytes, that could also indicate UTI. You can check for the presence of blood. That could indicate lots of things, including like just, maybe even physical blood and trauma. One of my students, he was a boxer. He got knocked right in the kidney, right? And he was peeing blood, hematuria for several days. And generally speaking, it resolves on its own, like it will get better again. But there's other conditions that you will see more like hematuria, and you can detect that with a urine analysis. Ketones, for a person who has DKA, diabetic ketoacidosis, you would see elevation in ketones. Glucose for diabetics, right? Bilirubin and urobilinogen can both indicate some form of liver damage. Proteins, you should not have proteins in your urine. That's proteinuria. That generally indicates that there's some sort of damage. So it could be like a nephritic or a nephrotic type syndrome. And so here's a good summary of everything that you would see on a urine analysis. Again, leukocyte esterase, nitrites, leukocytes, that would all indicate UTI. Urobilinogen, bilirubin would be liver issues, et cetera, et cetera. So other things that you should be familiar with in terms of terminology: pyelonephritis, that's when you have an infection of the actual kidneys itself. Cystitis is specifically the bladder, and then urethritis is the urethra. If a person has a UTI, the UTI that might just be starting sort of like in the urethra could eventually escalate into cystitis, and it could turn into pyelonephritis if it makes its way all the way up to the kidneys. How do you check for pyelonephritis? Remember we were talking about the Murphy's test when we were talking about GI? Right, that's where you dig your fingers really deep underneath the ribs, have the patient like take a deep breath in, pushes the gallbladder into your fingers. Right, so that's a positive Murphy's test. The other Murphy's test is the Murphy's punch test, which indicates costovertebral angle tenderness. And so you put your hand on the flank right behind the person's back, and you just do a gentle tap on your hand. And if that elicits pain, that is a positive Murphy's punch test, which indicates that the person probably has pyelonephritis. Now, let's talk about inflammation of the bladder itself. If you have inflammation of the bladder, that's referred to as interstitial cystitis, just painful bladder. That's effectively what this is. And it's chronic inflammation, and by and large, it is idiopathic. We're idiots and we don't know exactly what's going on. But we think that it might be autoimmune related because you see an increased rate of interstitial cystitis with patients who have systemic lupus erythematosus, SLE, lupus. Most often you'll see this in females. It's more common in females than men. And again, chronic inflammation, that's the main underlying cause. Eventually you get fibrosis. Mast cell overactivity with increased histamine release is going to be one of the underlying causes of this. So, with that being said, do you think that if a person took antihistamines, this might actually help a little bit? Yeah, actually, you could take antihistamines, and that might help prevent the pain, and also it can help to prevent excessive amounts of urination. Because with interstitial cystitis, these individuals usually want to use the restroom frequently, and if you ever take like Benadryl at night, especially before you go to bed, it helps to reduce nocturia. So as antihistamines can also have a little bit of an anticholinergic effect, and so it can actually help to retain urine for longer so you're not peeing as much. So that would be another thing that antihistamines could potentially help with patients with interstitial cystitis. So it reduces the histamine being released by mast cells, but it can also help to reduce the amount of urinary frequency. So signs and symptoms, frequency, right? Urgency and frequency, but also small urine output. You want to pee more, but you're not really peeing a lot when you do pee. You could see hematuria, and then dysuria is pain upon urination. And then with a lot of inflammation, you get fibrosis. And then this is one of the worst parts about it is these Hunter's ulcers. And the Hunter's ulcers especially get worse when you're peeing. And then as the bladder is being emptied out, those ulcers now can come in contact with other portions of the bladder. And so that can actually further exacerbate the pain from interstitial cystitis. And like I said, these people are peeing a lot, 60 times a day. That is a lot of peeing. Again, they're not peeing a lot in terms of quantity, in terms of volume, but they're using the restroom very often. So frequency, urgency, and you could rule out UTI. You could do a urine analysis, see if there's like leukocyte esterase, which might indicate infection. So this is not infectious, right? It's inflammatory. So you can rule out UTI. Your analysis is basically going to be within normal limits. Okay, that's one of the major things. You don't cure this. There's no cure, but you can treat it with pharmacological approaches. You can use tricyclic antidepressants. Again, antihistamines like hydroxyzine can be used. You can do botulinum toxin, or if it's really bad, you can remove the kidney. Remove the bladder. That's a cystectomy. And so there's a couple different types of cystectomies, which I'll show you in a second. But this is effectively things that you would find. Thinning of the walls of the bladder. You might see some pinpoint bleeds, and then those Hunter's ulcers are going to be the worst aspects of this. And it gets worse, especially when you deflate the bladder when you're urinating. And so when you're losing volume, then those ulcers can come into contact with the bladder wall, causing pain. If you remove the bladder, you can do a couple different things. You could do a neobladder, where they're creating a new bladder using a portion of the GI tract, or you could do an ileoconduit. And an ileoconduit is basically you're going to create basically an ileostomy kind of scenario, but it's going to be a urinary stoma. It looks like an ileostomy because it's using a portion of the ileum, but it's not truly an ileostomy. An ileostomy would actually be for like solid wastes, right? But one thing with the ureters is if you try to connect it to the outside environment, they tend to close up a lot. And so that's why surgeons will do a ligation between the ureters and the ileum portion of the bowel, and then they'll turn that into a stoma. So here's a little video where she's talking about the process of creating an ileoconduit.
An ileoconduit is a type of urostomy, a urinary surgical diversion commonly performed when removing the bladder. Now the name ileoconduit can be confusing, but it's really a great name for this procedure. Now please understand, the kidneys and the bladder normally sit behind the GI tract. I'm just sticking them on the front for convenience sake. Now, let me explain what is happening here. We've got urine produced by the kidneys, then moving down the ureter into the bladder. It exits the body via the urethra. Now, a woman's urethra would actually be much shorter than this, and a man's urethra would, of course, be much longer. Now, should the bladder need to be removed, a couple of options are bringing both of the ureters out of the body and having two ureterostomies. Or one ureter can be connected to the other ureter internally, so you would only have one stoma, and this is called a ureterostomy. Now, these methods are not frequently chosen, except in the case of premature birth, because the ureters don't make good stomas. They tend to stenose and harden over time. More often, the surgeon will remove a section of the ileum, the last section of the small intestine, then reconnect the GI tract back together. The small segment of ileum will remain connected to the natural blood supply to remain viable. Then the surgeon will close off the end of the ileal segment, leaving the other end of the segment open. Then the surgeon will implant the ureters into the segment of the ileum, allowing the urine to be able to drain freely out of the open end. Next, the surgeon will create a diversion by making an opening on the abdominal wall, pulling this open end of the GI tract through, folding it over, suturing it down to the body. And this is where the urine will exit the body. This will be known as the stoma. And you can expect to see mucus flowing from the urine that comes from a urostomy. If you would like to know more about urostomy surgery and management of urostomy, contact the UOAA.
I am now convinced I need to start wearing an apron with all the organs on it because that is so cool. It's a great way to demonstrate how things like that are done. So cool. All right, any questions on interstitial cystitis? All right, now let's talk about one of the most common infections out there, right? Urinary tract infections. So UTIs, they can involve urethritis. If it rises to the level of the bladder, it can cause cystitis. And if it rises to the level of the kidneys, it can cause pyelonephritis. Again, one of the most common infections, especially within a hospital. Why in a hospital? Catheterization, right? So Foley catheters predispose an individual to getting UTIs. Also, extremely common in older adults. I think I already told you guys the story about my dad who had a stroke last year. When his caretakers were telling me what was going on, he was having like these hallucinations and stuff. The first thing I thought wasn't stroke. I was thinking, oh man, he probably has a UTI. So I had my mom take him to the hospital. They ruled out UTI and then they did a head scan. They found out he had a stroke. But a lot of older people, especially in like long-term facilities and long-term care, especially if they are incontinent and they have to wear like, diapers, they're going to have a higher risk of developing UTIs. So if you're working in geriatrics, make sure to, if someone has like altered mental status all of a sudden, right, it could be a stroke. So you don't want to rule that out. But one of the first things that you want to check for as well is an urinary tract infection, which simple, quick test. You can just do the urinalysis dipstick test, right? And then also the urine would be a little bit foul, like malodorous. It'd be like a foul-smelling urine, more so than usual. So what's the major cause of UTIs? E. coli. E. coli is the number one bacteria that causes UTIs. There's other bacteria, though, that can cause UTIs. Proteus mirabilis, Pseudomonas can cause UTIs. There's a bunch of them that can cause UTIs. Serratia marcescens can cause UTIs. A lot of the gram-negatives that live within our GI tract are also a lot of the ones that cause UTIs. This is especially more common in females. Of course, women have a shorter urethra. On average, it's about like 1 to 2 inches long. Males' urethra generally around 8 inches long. So men usually get UTIs at a lesser frequency than women. So this is much more common in women. Postcoital. Coital means intercourse, right? So after a woman has sex, it is recommended to go use the restroom so you can flush out bacteria that might have inadvertently made its way into the urethra. Patients with diabetes have a higher rate of UTIs. They have lots of blood sugar. Bacteria loves sugar, so they get a higher risk of infections in general. Catheters, of course, hygiene, dehydration. If you're immunocompromised, those are all things that you would see as risk factors. Urethritis and cystitis. If you have urethritis and cystitis, you're going to have an urgency to use the restroom. You're going to feel compelled to use the restroom more and more. So you have increased urgency, frequency, and you also have dysuria, which means pain upon urination. Fever, that's usually a common thing that you'll see. Nausea and vomiting. You could see hematuria, but not always. You don't always see hematuria with an UTI. And by the way, symptoms of UTIs can look very similar to symptoms of sexually transmitted diseases too. So you get cystitis with like gonorrhea, with chlamydia. Not always. You don't always get, urethritis, but sometimes you do. The thing about STIs, which really sucks, is that a lot of times they're asymptomatic. Especially in women. They're much more asymptomatic in women. Here's another really sucky thing to keep in mind. In the United States, what's the most common UTI that's bacterial? Yeast infection is actually not bacteria. That's a fungus, right? It's Candida albicans. What's the most common? You said chlamydia? You did not say chlamydia, did you?
I did.
You did. You said chlamydia. Okay, yeah, chlamydia is the most common, second to gonorrhea. Gonorrhea is number 2, chlamydia is number 1. 1 in 20 people in the United States carry chlamydia. So watch out. And there's like what, about 23 of us in here in this room. So the thing is about those types of STIs is that they, a lot of times, like I said, they're asymptomatic, especially in women. So sometimes people have it and they don't know it, and they're just spreading it around. Another thing to keep in mind about STIs is that if you have chlamydia and you test positive, if you test positive for gonorrhea, you're going to assume that person has chlamydia because oftentimes they're co-infections. And you get a lot of false negatives with chlamydia. Even if a person has chlamydia, sometimes they test negative for it. And so when a person has gonorrhea, you're going to assume they have chlamydia, and so you treat them for both, assuming that they have both. Because a lot of STIs, they come in 2s, 3s, and 4s. One of the worst cases of STI I've ever seen in my life was this dude who had full-blown AIDS. Right? When you diagnose AIDS, you check their CD4 count. CD4 count, if it's below 200, you can go from HIV now to AIDS. Or if they have a AIDS-related infection like Candida esophagitis, Pneumocystis jirovecii infection, toxoplasmosis, a lot of those are going to be like AIDS-defining illnesses. This guy had a CD4 count of 1. We even joked, we're like, I think we took his last CD4 cell. And CD4 count of 1, he had like secondary syphilis. He had like scabies all over his body. He had ulcers on his genitals that were like unbelievable. I've never seen anything like it in my life. This guy was a walking nightmare. Like, I can't believe it took so long for him to actually come to the hospital. And he had to keep the room warm because he had fevers. So when you walked in the room, it was hot in there and it smelled like roast beef. And it was just like, this poor guy. And I had to take like a sample to see what the ulcers were being caused by. So I had to take an ulcer from his sample to send it off for like culturing. And he was just like screaming in pain. And then secondary syphilis. So we had to give him like penicillin G shots. And penicillin G, by the way, hurts like hell. When you get the shot in your gluteal muscles, you can barely sit down on the spot for like a long time. This guy was a mess. I feel so bad for him. I hope he's okay. And I asked him, like, so, what's your sexual history like? And he was like, oh yeah, I'm monogamous. He was a truck driver too. He was like, yeah, I'm only with this one girl. I'm like, okay. What's going on with your girl? He's like, oh, she's fine. Nothing's going on with her. I'm like, dude, your story does not add up. Anyway, so UTIs, they do look a lot like STIs. So, watch out for that. Anyway, so with a UTI, when you do a urinalysis, you're going to see bacteria, you're going to see nitrites, leukocyte esterase, white blood cells. All those things are going to be positive in a UTI. You can send a urine sample off to the lab to get culturing and sensitivity testing done as well. That's going to be the best way to diagnose what it is, right? So you can figure out what antibiotic you want to use. You can also do X-ray and CTs if you feel compelled to do so. You could see leukocytosis. Again, causative angle tenderness or the Murphy's punch test is going to be positive. Once you figure out what it is, you want to treat it. One of the most commonly used drugs is going to be Bactrim, which is trimethoprim sulfamethoxazole. So it's a combined drug, uses 2 similar mechanisms of action. So that's a very commonly used drug. And generally speaking, it can resolve after antibiotic therapy. What's up? Oh, that's way more severe. Yeah, pyelonephritis, when you're starting to infect the kidneys, that's that's advanced stage. Yeah, you want to definitely treat that, because if you don't treat it properly, that can cause some like severe damage to the kidneys. Yeah, so you want to use more higher dose, different routes of administration. So that's a great question. So these are all the things that are going to be elevated in UTI. This over here is showing all the normal ranges. But the highlighted in red are the things that you would see elevated. So you see elevated nitrites, leukocyte esterase, bacteria, white blood cells, and sometimes hematuria in patients with a UTI. Any questions on UTI? All right, cool. Let's move on to urinary incontinence. There's 3 major types of urinary incontinence. One of them is going to be stress incontinence. And this is going to be something that you see often in women. Why? Well, first of all, women's urethra is a little bit shorter. But why else might you see this in women? After childbirth, yeah, especially women who have delivered multiple children. That can tend to weaken things a little bit, right? It's going to weaken like the pelvic floor muscles, and it can also cause some issues with the urethra. And so stress incontinence, this would be like increased pressure within the abdomen causes the person to urinate a little bit. So this can happen with something as simple as laughing at a joke and then peeing a little bit, coughing, sneezing, lifting weights. So those are all things that you might see. What could you do to help? You could do like Kegel exercises. So oftentimes when a woman gives birth, like afterwards, she'll like, you know, go into like what do you call it, like physical therapy type of thing where you increase your, you know, Kegel strength and pelvic floor muscles. So you can do Kegel exercises to help with that. Urge incontinence. This is going to be something you see in more like older people. This is where you have the detrusor muscles are basically like freaking out and they're starting to like contract when they shouldn't be. So you have hyperreflexia of the detrusor muscles. So you have involuntary loss of urine. You get dripping all the time. You get peeing at night, which is nocturia. This can also happen to people who have neurological disorders. So people with like stroke, Parkinson's. That's a very common theme with those types of patients. There's another subcategory of incontinence. It's called neurogenic incontinence. That falls under this category. And I have this like slide over here. I cropped it down because it's had a 4th column as well. And the 4th column is neurogenic incontinence. But neurogenic incontinence falls under urge incontinence. So urge incontinence where you have basically contraction of the bladder when it shouldn't be, or if you have like stroke or Parkinson's and things like that that cause neurogenic issues. The other one is going to be overflow incontinence. Overflow incontinence, as this image here shows, and as this image shows even better because now this one includes a prostate. That's what this is right here. That's a prostate gland. A person who has benign prostatic hyperplasia, BPH, which is benign, it's not a big deal. Like most guys who make it to the age of like 60 and 70, they're going to have BPH. And you can treat it with drugs like finasteride. Finasteride, 5 milligrams daily is one way you can treat that. A person who has a prostatic hyperplasia, that constricts the urethra, right? And so it's going to prevent urine from passing through. And so their bladder is going to be full. So they're going to try to go pee, but they're not going to be able to eliminate all the urine from their bladder. And so signs and symptoms, it looks kind of like a UTI. You get urgency, frequency, dysuria. You get also maybe pain. A family friend of mine, he had this really bad, and he said that he was like a detective for bathrooms, because everywhere he would go, he would like try to find where the bathroom's at. He actually had a procedure done to try to help alleviate that. And now, on the other hand, he has incontinence. And now he's like peeing all the time. He has to wear diapers. And it's like double-edged sword. You know, it's like what's worse, right? Having the overflow incontinence from BPH, or is it worse to have to wear diapers? I don't know. So these issues tend to be pretty difficult to treat. He's gone to his urologist multiple times, and I think he's going to be doing another procedure sometime soon, hopefully to help. So we'll see. Testing, you do a clinical history. You could also do ultrasound. But again, it looks like a UTI, so you want to rule out UTI. So stress incontinence, think about a person who's like maybe lots of pressure, maybe they're laughing, maybe even they're pregnant. Even while you're pregnant, right, the baby as it's developing in the uterus is going to push against the bladder, so that can cause stress incontinence. Urge incontinence, think about like neurological issues, for example, or detrusor muscle hyperreflexia, and then overflow incontinence. Think about BPH, benign prostatic hyperplasia, and the bladder is always going to be full, basically. Any questions on incontinence? All right, let's talk about kidney stones. Nephrolithiasis. Nephrolithiasis is extremely painful. I've never had it happen to me before, but when I was doing undergrad at ASU, a friend of mine, he got a really bad case of nephrolithiasis, and he said he was immobilized. He was like on the ground, just like writhing in pain because it was so extremely painful. Has anybody in here ever had a kidney stone before? Nobody. Good. I hope it stays that way because you wouldn't want to wish kidney stones on your worst enemy. It's like 10 out of 10, extremely painful. But for us guys, it's going to be more common in guys. Lifestyle factors. I was looking this up the other day. I was like, why is it more common in guys? It's because guys tend to have a higher protein diet and they tend to eat more salt. So that's basically it. And those two things are going to predispose men, especially, to developing nephrolithiasis. More common in Caucasians, no idea why. Maybe it also has to do with lifestyle. I don't know. If you have one, your incidence of getting, or your chances of getting another one is way higher. I had a student in my AMP course a couple weeks ago in class. She was asking me, why do people get UTIs? Could it be genetic? And yeah, it could definitely be genetic. So sometimes it can, there might be a genetic underlying cause for it. Her dad has had 10 kidney stones in his life. By the way, did I say UTIs? I meant kidney stones. Her dad has had 10 kidney stones in his life. Like, that's insane. And every single time, extremely painful. It's a very, very painful condition. And so he has to drink lemon juice. Right? So increasing the amount of acidity in his urine helps to break down the kidney stone. Why? Calcium. Calcium oxalate is going to be one of the major kidney stones. Things that have calcium in it tend to get degraded in the presence of acidity, right? So that's one thing that you can help to do. Other things that cause it, dehydration. So if you're not drinking enough water, if you're living a very sedentary lifestyle, or taking certain medications. There's certain meds that can predispose people to nephrolithiasis. Calcium oxalate and calcium phosphate are going to be some of the more common ones. But let's watch a little thing here. Again, very long video. I'm not going to play the whole thing.
A kidney stone can be as small as the head of a pin, almost invisible to the naked eye. But as every stone former knows, the pain resulting from this tiny crystal structure can be enormous. Inside kidney stone disease. Kidney stones, or renal calculi, are aggregates of crystals enclosed in a matrix that develop within the kidneys. They're classified according to the specific types of crystals they contain and fall into 5 major categories: calcium oxalate, calcium phosphate, struvite, uric acid, and cysteine. The most common is calcium oxalate. How is a stone formed? The first step is nucleation. Ions such as calcium and oxalate that have been filtered into the urine by the kidney spontaneously join together to form a solid crystal nidus. This is called nucleation. There are 2 kinds of nucleation. In homogeneous nucleation, crystals form around a nucleus with the same composition. Crystals of a different composition can also form around the nucleus. Organic materials such as cell debris may be deposited between the crystals as a matrix. This is heterogeneous nucleation. The tiny crystal formations travel down the nephron and are usually deposited at the renal papilla, where they undergo the next major phase, growth. Crystals that have already formed then begin to stick together, forming large aggregates. As we can see, crystals can aggregate very quickly. New stones are retained in the kidney, where they can continue to grow for an unspecified length of time until, for reasons that are not well understood, they are displaced and travel through the kidney into the ureter.
All right, so if you want to watch the rest of that video, do so on your own time, but that's a nice little depiction of how the kidneys are formed. So again, calcium oxalate, the most common kind. Where does oxalate come from? That's going to come from diet. So veggies, fruits, nuts, grains, things like that. You can also find it in things like soy, almonds, etc. So that's where the oxalate comes from. If you're immobilized, if you're like hypoactive, you don't really do much, right? You're not doing much at all. You're going to start getting demineralization of bones. Right? So sedentary lifestyle is going to be one of the major causes of this. So you get hypercalcemia, and hypercalcemia can start causing stone development within the kidneys. Struvite stones, those are your staghorn kidney stones. Those are secondary to UTIs. So Proteus mirabilis is going to be one of the major causes of that. You can also see that in Klebsiella and Pseudomonas as well. And then uric acid stones. Remember we were talking about gout. If a person has gout, they're going to have a higher chance of developing uric acid stones, right? Because uric acid is going to be characteristic of gouty arthritis. So how does the stone form? You get that nucleation, right? Then you get hypersaturation of the salts. They precipitate out, and then they start to crystallize, and they start to grow within the kidney. I mean, look at this one right here. That's insane. All those kidney stones developed within the person's kidney. Must be absolutely brutal. So calcium oxalate, most common of them all. So hypercalciuria, if you have too much calcium in your blood, you can get that from parathyroid issue. So if you have hyperparathyroidism, that can cause this. If you have too much oxalate, that can also cause this as well. And if your urine is too alkaline, that can also cause that. That's why if you are predisposed to getting kidney stones, you want to maybe increase the amount of like acidic things that you're consuming, like lemon juice, for example. Uric acid stone, again, that's going to be associated with gout. Then your struvite stones, those are made with a couple different things coming together, magnesium, ammonium phosphate, and again, infections, right? Klebsiella, Proteus, and then it causes a staghorn calculus. Absolutely huge kidney stone. The staghorn kidney stones are basically going to fill up all of these regions. The minor and major calyces are all going to be taken up by a staghorn kidney stone. The stones are not going to be released if they're bigger than 1 centimeter. If it's less than 5 millimeters, which is still pretty dang big, right? Less than 5 millimeters, it can usually be released spontaneously. But if a stone is bigger than 1 centimeter, it's not going to spontaneously be released. You're going to have to do like a lithotripsy, which I'll play a video of what that looks like in a second. So there's different procedures you could do. The symptoms can vary depending on severity, right? So if it's not a huge stone, it can be pretty moderate. But if it's really bad, it can be extremely painful. I'm talking 10 out of 10 pain. Where does the pain start? It starts at the flanks, and it basically just follows the ureters. So it goes from the flanks all the way down to the groin. So that's the location of pain. And you could also get obstruction of the ureters, which can cause issues with the kidneys as well. So you can get damage to the kidneys if you have some severe obstruction. Nausea and vomiting is really common. Dysuria, obviously, and blood. So you can get hematuria too. You can do all sorts of different tests. Urine analysis, CT scan. You can do a renal function test if you wanted to. You can look at their calcium and PTH levels because that can indicate the underlying cause. So here are some of the treatments that you can do. You can do a ureteroscope. Let's see a video of that.
What is ureteroscopy? Ureteroscopy is a type of surgery to treat kidney stones. A surgeon does the procedure in a hospital operating room or an outpatient surgery center. Ureteroscopy usually takes 30 minutes to 2 hours. The procedure typically requires anesthesia. However, the doctor does not make any surgical cuts or incisions on the outside of your body. Once you are under anesthesia, the doctor uses a videoscope called a ureteroscope to examine your urinary tract, including your kidneys, ureters, and bladder. The doctor locates the kidney stone.
and breaks them apart using laser energy, or removes the stones using a small basket. At the end of the procedure, your doctor may insert a small plastic tube called a ureteral stent in your urinary tract to help control swelling and allow the kidney to drain urine. The stent typically remains in your body for 4 to 7 days and is then removed during a follow-up appointment.
All right. And then the other type of procedure that you could do, shockwave lithotripsy. So this is a pretty cool procedure.
Lithotripsy, or extracorporeal shockwave lithotripsy, is a procedure used to treat kidney stones. It takes place while you lie on a special lithotripsy couch. When the stones have been located, the lithotripter can be trained on them. Because it can be uncomfortable when the kidney stones break up, you'll be given painkillers before the procedure is started. The lithotripter directs sound waves towards your kidney stones. This can be quite loud. The sound waves break up the kidney stones. The procedure usually lasts about 45 minutes to 1 hour. The broken up kidney stones are passed in your urine over the next few days. This is the end of the animation. Click on the animation screen to watch it again. This animation will show how
Anyways, all right, so here's another picture of the staghorn kidney stones. Like, look at the size of those things, man. That's absolutely huge. Again, secondary to UTIs, urinary tract infections, specifically Proteus mirabilis. That's one of the major ones. What's up?
Is that something that like you start to feel over time, or one day you're just like?
That's this staghorn kidney. So it's due to like recurrent urinary tract infections. So I think it develops over time. So yeah, your symptoms will probably get worse and worse and worse as it progresses. So yeah, that's a good question. So I mean, a stone that big definitely would take a while for it to develop because that's absolutely huge. Any questions on nephrolithiasis? Kidney stones. All right, great. So let's move on to other pathologies. So we're going to talk about glomerular diseases. So there's a couple different types. There's nephritic and nephrotic syndrome. Those fall under glomerular nephritis. There's also tubular diseases. So acute tubular necrosis, that's where you get death of those tubules. And then there's other things like AKI, CKD, and then we're going to talk about polycystic kidney disease in a second here, and then pyelonephritis. So let's focus on polycystic kidney disease now. Polycystic kidneys, you get a lot of fluids that fill up the kidneys, and the kidneys become huge. Look at the size of these things. Imagine that inside your body is the size of a football. Massive. So the patient that develops polycystic kidney disease, especially the autosomal dominant, because that's the one that affects adults, they're going to start feeling fullness in their flanks. They're going to start getting like they're going to feel like a large abdominal mass, right? That's the kidney. And really, really, really big. The kidney generally is about the size of a fist, right? So compare that to the size of a football, right? Really huge. In building 1, we have a bucket of organs there that we got from the cadavers here. And one of the buckets we have is a patient that had polycystic kidney disease. And the kidneys are about this big. So we do a dissection in there with pig kidneys. Pig kidneys are really big. It's probably because they're like metabolizing lots of gross stuff. And so they have really big kidneys. The polycystic kidney is about the size of a pig kidney. So really huge. So the two types are autosomal dominant and autosomal recessive. Autosomal dominant is the one that affects older individuals. And it's going to be one of the most common types. Autosomal recessive is the one that affects young individuals. So neonates, infants, young children. What are the signs and symptoms? You're going to have hypertension is one of the signs. Pain, the abdominal mass or mass in the flanks in the back. You could get hematuria, UTIs, and it has to do with connective tissues. So you might see issues with blood vessels too. So you could see higher rates of aneurysms in these patients, not just because of the connective tissues, but also because the hypertension can also predispose a person to developing aneurysms. They can get other issues with connective tissues that could affect the heart. So you can get mitral valve prolapse, right? So there's lots of other things you can get with polycystic kidney disease. You want to image it, so you want to see what's going on, and then you can also do genetic testing to see what's happening there. Let's watch this fun little video. It's very short, but it's super cool.
Got it?
Yep.
It's amazing, huh? It's all just fluid filling up all those cysts.
Each one of these.
They're having way too much fun. Looks like he's getting ready to put it on a grill or something. I don't know. You guys get the picture, right? Look at that CT scan. My God. The abdominal mass, it's even like protruding out through the sides of their abdomen. It's insane. Huge. All right, any questions on polycystic kidney disease? So just remember, autosomal dominant adults, autosomal recessive young individuals. Those young individuals don't tend to do so well. Unless they can get a renal transplant, because that's basically the only cure is getting a renal transplant. So not great. All right, now let's focus on glomerulonephritis. So the glomerulus, what does the glomerulus do? What's the major? There's three things the kidney does, right? One of the things happens at the glomerulus. Do you guys remember? Yeah, filtration. So filtration happens at the glomerulus, right? Then you have reabsorption, especially at the proximal convoluted tubules. Then you have secretion, especially at the distal convoluted tubule and collecting ducts. So glomerulonephritis is going to affect the glomerulus, and it's going to affect GFR, or glomerular filtration rate. You can get acute or chronic, different types, right? Some of the most important ones that we're going to cover today are Buerger's disease, which is one of your IgA nephropathies. There's also post-infectious glomerulonephritis, which is going to be generally caused by streptococcal infection, strep pyogenes specifically. There's also ischemic type disorders, right? So you can get ischemia, you can have autoimmune deposits. That's generally also associated with post-infectious disease. There's certain drugs that can affect the glomerulus, different types of vasculitis. So lots of things can cause glomerulonephritis. But the ones that we're going to focus on are Buerger's disease and post-infectious glomerulonephritis. Symptoms. Generally speaking, you're going to get hematuria, and it's going to look like cola. So it's going to be Coca-Cola colored, so really dark brown. Urinalysis. You're going to get red blood cell casts, proteinuria, because you're going to be releasing lots of proteins. And because of proteinuria, you're going to be losing proteins like albumin. When you lose albumin, you start swelling, right? So you're going to see things like swelling, especially in the lower extremities. So edema, also hypertension. And then because you're impairing renal function, you're going to get azotemia, so increased BUN, creatinine, and reduction in GFR, or glomerular filtration rate. So this is what the urine would look like. It looks like Coca-Cola. So just really, really dark brown. What's going on here? One of the major things that's happening is these antigen-antibody complexes. This is especially something you will see in like post-infectious glomerulonephritis. You have antigen-antibody complexes basically lodging in to the glomerulus and causing all sorts of inflammation and damage. Proteinuria, so you're going to be losing proteins. You're going to develop, because of that, hypoalbuminemia, right? Your serum level of albumin is going to drop. That's why you get swelling and edema. Something else that you could see too, and when a person urinates, they have lots of protein in the urine, the urine's going to look very frothy. So if you have very, very frothy urine, that means you have lots of proteins within the urine. You're also going to get hematuria, of course, Coca-Cola colored urine. What else? Oh, inflammation. You can get platelet aggregation. The platelets could cause thrombi within the glomerulus. That also reduces GFR. Now, we're going to talk about nephritic versus nephrotic syndrome in a second. So those are things you might see, different varying degrees of protein loss, as well as blood in the urine. Edema, because of the loss of proteins. Proteinuria, obviously. GFR is going to be low, and then you're going to have azotemia, and then you're going to have decreased urine output. So if you measure ins and outs, that's like fluids in versus fluids out. You're going to have decreased urine output. You want to do a biopsy on these patients. You want to do a biopsy so you can see what's going on at the level of the glomerulus, right? So you can see like immunological, like these immune complexes binding at the glomerulus. So electron microscope, also immunofluorescence stains for that. All right, now let's focus on nephritic versus nephrotic syndrome. So with nephritic syndrome here, these are some common causes. The ones we're going to focus on are the ones I highlighted here in yellow. So post-infectious glomerular nephritis. So that's PIGN. And then the other one that we're going to focus on is IgA nephropathy. The two major IgA nephropathies is Berger's disease as well as Henoch-Schönlein purpura. Henoch-Schönlein purpura nephritis. Generally happens with kids, but guess what? I have a student in one of my classes who developed Henoch-Schönlein purpura when he was 20 years old. So it's not always kids. It can also happen to older adults as well. And it's an autoimmune condition, and it's one of the few autoimmune conditions that can sometimes just fully resolve on its own. So he hasn't had an attack with this. It was interesting. He was telling me about the progression. He was in the hospital for like a month and a half, and the doctors had absolutely no idea what the heck was going on with him. And he was just like sick as a dog until one day, I think it was like one of the urologists, because they thought that he had all sorts of different, they thought he had different autoimmune, they didn't know exactly what was going on with him. But they had one doctor come in who had an autoimmune disorder, and he was like, this looks really familiar. Like, this looks like an autoimmune kind of disease. Let's go see if we can test for like antibodies and things like that. And then they did a biopsy, and sure enough, it came back positive for this form of IgA nephropathy, the Henoch-Schönlein purpura. So that's what he had. Purpura, you get these purpuritic lesions on the skin, and then all the symptoms of nephritic syndrome. Nephrotic syndrome, these are the other common causes of nephrotic syndrome. I'm not going to test you on these, but these are some of the common ones that you might see if you were to study nephrology in more detail. So let me go ahead and let's discuss nephritic syndrome more. So what's going on with nephrotic and nephritic syndrome? Basically, you're increasing the permeability at the level of the glomerulus, right? Because these are glomerular nephropathies, right? So you're increasing permeability, and so you're going to increase the space that allows more things to pass through. So with nephritic syndrome, you're going to see proteinuria. So you're going to see a lot of protein in the urine. Not as much as nephrotic syndrome. Nephrotic syndrome, you see a lot of proteins in the urine. Okay, so nephritic syndrome is a little bit less. But with nephritic syndrome, you're going to see more hematuria. You're going to see more blood in the urine with nephritic syndrome. And it's inflammatory in nature. So you're getting lots of inflammation as the cause for that. So signs and symptoms in the labs, urine analysis, you're going to get proteinuria, hematuria. You're going to get these red blood cell casts. Right? Remember, those are the clumps of red blood cells that form these like little tubular type formations. Oliguria, reduction in urine output, hypertension, edema. Again, though, not as bad as nephrotic syndrome. Nephrotic syndrome, you're losing way more protein, so the edema is going to be more severe. And then azotemia with the BUN and creatinine and reduced GFR. Now, nephrotic syndrome, similar to nephritic syndrome, you have increased permeability. However, you're going to lose a lot more protein. So it's going to be a massive amount of proteins that's going to be lost, including albumin. You're not going to get as much hematuria, though, right? So there's going to be no hematuria with nephrotic syndrome. It's mostly going to involve proteins. So with hypoalbuminemia, you're going to get edema. Right? Reduced capillary osmotic pressure. So you're going to get edema. You're also going to get reduced urine output too. The proteinuria, that's going to, you can see it with the foamy, frothy urine. When a person has lots of froth in their urine, that's proteins. You're also going to lose thyroid globulins. And so you get hypothyroidism a little bit. And then hyperlipidemia. If you have less albumin, you're going to see the liver coming into play to try to create more albumin. It's going to try to make more LDLs and triglycerides. And so you're going to get hyperlipidemia with this. So here's a good schematic that shows you the difference between the two. So with Berger's disease, right, you get the cola-colored urine, right? So the urine's going to be really dark. You're going to see hypertension, oliguria. So that's more of your nephritic syndrome versus nephrotic syndrome. You're losing a lot of your proteins, right? So you get lots of edema because of that, and then hyperlipidemia as a consequence. And here's another breakdown of all the signs and symptoms in comparison. Nephritic, you get proteinuria, but not as bad. Hypertension, all of that. Oliguria, azotemia. You do get hematuria with nephritic syndrome specifically. And these are the two major kinds that we're going to talk about, right? Post-infectious glomerulonephritis and Berger's disease. And then you got your nephrotic syndrome. Nephrotic, think about the O in nephrotic as allowing a lot of the proteins to just move through, right? That's one way you can think of it. Nephrotic syndrome, O, protein just comes right through it, right? So you get lots of proteins and lots of edema because of that. And here's another chart that I included for you guys that helps to summarize the key findings between the two. Edema is going to be more so in nephrotic syndrome. Think O, proteins are moving through. What else? Proteinuria, obviously. Albumin is going to be low. Versus nephritic syndrome, the biggest difference is going to be red blood cells, right? You're going to get hematuria in that. So that's the major difference. All right, any questions on the broad categories of nephritic versus nephrotic? All right, let's move on. Let's focus now on post-infectious glomerulonephritis, or PIGN. This has also been referred to as post-streptococcal glomerulonephritis because it often involves streptococcus infections. This is going to affect more younger individuals. So a young person who gets like strep throat, or maybe they get impetigo, right? So those are things that might predispose a person to getting this. So they get an infection, and then a couple weeks afterwards, that's when they start developing the PIGN. What's one of the most common causes? It's going to be your group A beta hemolytic streptococcus. What bacteria is that? Huh? HIV. No, it's going to be streptococcus. So Haemophilus influenza is a gram-negative. This is a gram-positive organism. So strep pyogenes. Strep pyogenes is the main cause of strep throat. It does a lot of other things too. It can cause necrotizing fasciitis. It can also cause impetigo too. Usually impetigo is going to be caused by Staph aureus, but strep pyogenes is a really bad infection. It's really, really nasty, very aggressive. It can also predispose a person to developing scarlet fever. Remember we talked about rheumatic heart disease earlier on in the semester? That's one of the things that you can see. It can also cause this, post-streptococcal glomerulonephritis. So that's your beta hemolytic strep pyogenes, nasty bacteria. Immune complex deposition, that's going to be the hallmark for this. So you're going to see all those immune complexes depositing within the glomerulus and causing inflammation of the glomerulus. Fever, edema, flank pain, those are all things you could see. If a person has a strep infection, you can look for anti-streptolysin O antibodies. That's going to be one of the key findings on your labs that can help you diagnose this. Other things you're going to see, hematuria, proteinuria. You're going to see your red blood cells, right? Because it's a nephritic type disease. So you're going to see red blood cells, red casts, Coca-Cola colored urine, right? So it's going to kind of look like Berger's disease a little bit in that regard. You're going to get sodium retention because you're not excreting it as much as you otherwise would, right? So that causes hypertension, edema, and then azotemia again. That's another thing you're going to see. So that's a red blood cell cast right there. So it looks, you can see all the red blood cells is kind of clumping up together, forming like a tubular type structure. And you'll see that within the urine under microscopy. This is impetigo, so that's the mouth right there. You see the lips. Impetigo, you get these crusty type lesions. They call it like a honeycombing type crust lesion, right? Because as the vesicles burst, you get like some purulence that kind of comes out, causing the crust. And then this is the periorbital edema that you would see as well. All right, the other type that we're going to focus on of nephritic illness is going to be IgA nephropathy, aka Berger's disease. Right. There's also the Henoch-Schönlein purpura. We're not going to talk about that in much detail. But Berger's disease is the other one that you're responsible for. You get IgA deposition in the glomerulus. This is the most common cause of glomerulonephritis. More so in men, and it usually is going to be associated with an infection. So you have like an upper respiratory infection or maybe a GI infection, and that is what basically predisposes a person to developing IgA nephropathy. Where do you find IgA as an immunoglobulin in the body for the most part? Mucosal membranes. Yeah, so mucosal membranes, especially in the GI tract, you're going to see lots of IgA. IgM is in the blood. IgG is what crosses the placenta for women. So you find different immunoglobulins everywhere. But IgA is going to be associated with mucosal membranes. So that's why it's going to be post-infectious. Signs and symptoms, again, dark urine, right? So really dark brown urine, bloody urine. Unfortunately, high rate of just all-out renal failure. It can become chronic kidney disease in about 25% of cases. So 1/4 of these people are going to likely have to go into dialysis. So not a good situation. Again, azotemia is going to be the main thing that you find on the tests. Proteinuria, hematuria, cola-colored, right? So your typical nephritic type symptoms. You can get hypertension, edema, and biopsy. You want to biopsy these patients. So you biopsy it and you see IgA deposits in the glomerulus. No cure. You can slow the progression. And again, like I said, a very huge percentage of these individuals have to go into dialysis, or they might have to go get a renal transplant. So definitely sucks, right? Out of nowhere, you get an infection, and then you get IgA nephropathy. It's horrible. This is actually not from my medical school notes. My medical school notes were a little bit different. I hand drew everything. I had to turn it to art school because as an artist, medical school really kind of killed me. So I had to make it interesting. And so I turned it all into art. But this is Dr. Jackson's medical school notes when it came to nephritic and nephrotic diseases. Just wait until you guys get to med school. For those of you who are planning on going to med school, this is the kind of crap that you're going to have to deal with. Just lots and lots and lots of diseases, all different kinds of diseases, all the different treatments and all that stuff. So fun times. You guys are lucky you don't have to deal with all that just yet. All right, any questions on nephritic versus nephrotic diseases? Nephrotic syndrome. All right, let's talk about acute kidney injury. So if you have acute kidney injury, this happens rapidly. You're going to see azotemia, again, reduction in GFR, and it can turn into chronic eventually. Causes, pre-renal, intrarenal, and post-renal azotemia. Pre-renal is before you get to the kidney. That means that it's generally due to hypovolemic shock. So if you have low blood flow to the kidney due to shock, maybe you hemorrhaged, or maybe you have septic shock, this is one of the things that you see with end organ damage. When we talk about end organ damage, this is one example. Right? So end organs, if you're getting hypoperfusion of the kidneys, that can damage the kidneys, and that causes pre-renal azotemia. Your BUN levels are going to be really high with this case. Intrarenal azotemia, that happens within the kidney, that's going to be associated with the acute kidney injury. That's where you just get damage, right? This could be inflammatory, it could be due to drugs, right? That's one thing. And then post-renal, after the kidney, this means you have urinary obstruction. That is usually going to be caused by nephrolithiasis. So if you have nephrolithiasis or benign prostatic hyperplasia, that's what BPH stands for, those are some of the major causes of post-renal azotemia. And then also, of course, bladder tumors can also cause that too. We're not going to go into bladder tumors. Bladder cancer, you see this very often, especially in Asian populations. Asian populations that consume lots of like smoked fish, smoked meats, smoked fish, things like that, have a higher rate. You predispose a person to developing bladder cancer. But we're not going to talk about that in too much detail today. Signs and symptoms, you get reduced urinary output, edema, you can get altered mental status. Your urine output is going to be greatly reduced. Your BUN and creatinine are going to be elevated. We'll talk about that in a second. Electrolytes are going to be out of balance. And then you can test using an ultrasound, which is the KUB ultrasound. That stands for kidneys, ureters, and urinary bladder. And you can also do a CT scan as well. So when you're diagnosing these different types of renal issues, you can do a BUN to creatinine ratio, and those can be different depending on what the underlying cause is. So if it's pre-renal azotemia, your BUN levels are going to be higher. And so your BUN to creatinine ratio is going to be greater than 15:1. If you have intrarenal azotemia, your creatinine is going to be what's a little bit more elevated. Your BUN, not as much, so the BUN to creatinine level is going to be less than 15:1. And then post-renal azotemia, again, it's going to be similar to pre-renal, where your BUN to creatinine levels are going to be greater than 15:1. So here's another summary of all those different things that can cause acute kidney injury. So pre-renal, hypotension, hypovolemia, cardiac output is decreased. Post-renal is obstruction, and then if you have intrarenal or intrinsic, that could be due to damage of the kidney itself, right? So glomerulonephritis, other things, necrosis, acute tubular necrosis, and interstitial nephritis. So those are all things that can cause damage to the kidneys. So let's kind of talk again a little bit about these tests, right? So you got your BUN to creatinine ratio is going to be very high when you have pre-renal azotemia. So BUN is going to be elevated more so than creatinine. Oliguria, you have reduction in urination, and then these are the causes, right? Dehydration, hypotension, aka you're hypoperfusing the kidneys. You have reduction in blood flow. Intrarenal, again, creatinine is going to be elevated more so, so the ratio is going to be less than 15:1. Similar though, you get oliguria, but the causes are different, right? It could be necrosis, glomerulonephritis, and then post-renal, we have blockage due to a kidney stone. BUN is going to be higher. And here's another, chart that basically talks about BUN to creatinine levels. These are the BUN and creatinine levels that are normal, and if they're abnormal, it could be due to any one of those three underlying causes: pre-renal, intrarenal, or post-renal azotemia. So any questions so far? All right, cool. So let's keep on going. I'm not going to rehash all this, but these are all the things that you might see in terms of oliguria, and then the effects that you're going to see in terms of like hormone secretion. Like you'll get like increased aldosterone secretion, increased ADH secretion, because of your reduction in GFR. So all this stuff is, things that you're going to see eventually resulting in oliguria and reduced GFR. Any questions on acute kidney injury, or AKI? Let's talk about acute tubular necrosis. So this is one of the most common causes of AKI. So you have death to the tubular epithelial cells. So that results in acute tubular necrosis. What is the major finding? Highlight that: muddy brown casts. So that is a muddy brown cast, and that muddy brown cast is going to be one of the hallmarks of acute tubular necrosis. What's the cause? Ischemia, right? So reduced blood flow to the kidney. It could be due to sepsis, it could be due to shock, it could be due to stenosis of the renal artery. Whatever reduces blood flow to the kidney can cause acute tubular necrosis. Not a great situation. Other causes. Certain drugs can cause this too. Aminoglycoside antibiotics. Lipitor, atorvastatin, can also cause this. Cisplatin, which is a anti-cancer drug, can also cause that. And if a person has antifreeze toxicity, ethylene glycol, that can cause it too. Muddy brown cast, that's the main thing I want you to keep in mind. How do you treat it? You want to give them fluids, and you want to, if they're taking meds, stop the meds, right? So you discontinue the drugs. What's up? It's if someone's trying to commit suicide.
Is that a common?
It's not common. It's a really stupid way to try to commit suicide, drinking antifreeze, but people do that. Antifreeze also tastes kind of sweet. So some people with mental health issues sometimes also drink antifreeze. So yeah, it happens. It happens enough, right? Yeah, I don't know. I've personally never seen it before, but it happens. Don't drink antifreeze, guys. There's better things to drink out there. All right, GFR. Any questions on all that, by the way? All right, so GFR. This is the way that you want to test to see how well the kidney is functioning. So glomerular filtration rate. So you want to make sure that the glomeruli are able to filter out urine from the blood. So this is how you assess the stages of kidney failure. So stage 1, kidney might be damaged. Things that can cause that, I don't know, maybe the person was a boxer and got hit in the kidneys. Or maybe they received IV contrast without getting a bolus of saline. If a person is getting IV contrast for like a CT scan or something like that, generally you want the person to be well hydrated. So you give them a 1 liter bolus of saline beforehand, before you administer the IV contrast, because you can get contrast-induced nephropathy. So it can cause damage to the glomerulus. But it's usually transient. It doesn't last very long. So the person will usually bounce back and go back to normal. Once you get into stage 4 and 5, that's when you have to go on dialysis. Severe renal failure is stage 4 and 5. And dialysis is not fun. When a person goes in dialysis, they go in 3 times a week. Each session lasts 4 hours. And by the time they're done, they are absolutely exhausted. Right? It's extremely draining. You're hooked up to a machine. It's taking your blood out, and it's running it through a dialysis machine so that it can filter out all those waste products, nitrogenous waste. On top of that, a person who's on dialysis, they can't really drink much water throughout the day. They have to do ice chips to like wet their palate. That's basically it. So not a great situation. So acute kidney injury, of course, can eventually develop into chronic renal disease, chronic renal failure. These are all the signs and symptoms of chronic renal failure. You can get like increased blood pressure, increased BUN, right? Your blood urea nitrogen is going to be really high, fatigue, weakness, oliguria, all that stuff. Why anemia? What are the 2 things that are produced by the juxtaglomerular cells in the glomerulus? Do you guys remember? There's 2 things that are released. Yeah, EPO and renin. Renin is released if your blood pressure is down or your blood volume is down, so you can increase your blood volume. And then also erythropoietin is going to be released by the juxtaglomerular cells. And so if your kidneys are damaged, you're not going to really be getting much EPO released, so you're going to become anemic as a consequence. Test, again, they have azotemia, low GFR, and they have to go on dialysis or receive a kidney transplant. Let's watch a little video here.
Kidney disease is the 8th leading cause of death in the United States. An estimated 31 million people in the United States have chronic kidney disease, also known as CKD. Patients with CKD have 2 treatment options, a kidney transplant or dialysis. However, there are more than 90,000 people on the waiting list per year for a kidney transplant. so the chances of an individual receiving a transplant are very slim. Under those circumstances, most CKD patients must receive dialysis. There are two types of dialysis, hemodialysis and peritoneal dialysis. But what is hemodialysis?
Hemodialysis is one kind of dialysis, which usually is performed in the center. And hemo means blood, so blood dialysis. A small amount of your blood is taken out of your body at one time and put through a filter and clean and put back in. That's done over and over a period of 3 to 4 hours, usually 3 times a week. In order to get the blood, you have to have a way to access the bloodstream. And the most common way that's done is something in your arm under the skin. It's something called a fistula.
And it does require placing needles into this access. 2 needles are required, one to take the blood out of the body so that it goes through the machine and through the filter, and then a needle to return the blood to the body after it's been cleansed.
With that in mind, what is peritoneal dialysis?
We have a membrane called the peritoneal membrane. It is a lining of our abdominal cavity, and fortunately we can use that peritoneal membrane as a filter.
And the peritoneal dialysis is where you have a catheter in your abdominal cavity and where you do something called an exchange, where you put some fluid in your belly, let it dwell for a little bit, and then you drain it out. And as you drain it out, that takes out all the waste products and some fluid along with it.
Well, there's 2 choices for peritoneal dialysis. There is the manual bag, in which you do an exchange 4 times a day, and then there is the night cycler method, of which when you're ready to go to bed, you hook up to the night cycler, and it does these exchanges for you automatically.
Although dialysis is not painful, patients endure these scars of needles entering their arms or abdomen, as they must return for treatment at least 3 times per week. CKD significantly changes the lifestyle of those who have fallen victim to this disease. Patients must change their previous eating habits and be placed on a strict diet. Patients must also implement specific medication into their lives in order to function properly throughout their day.
You notice a massive HIPAA violation right there? It showed the patient's name on the freaking bottle of their prescriptions. Anyways. So that's dialysis in a nutshell. So not great. So you have to get that fistula. The surgeons are the ones that create the fistula. So they're basically kind of rerouting a blood vessel, and then now you get dilation of that blood vessel. And so you get more blood pooling there, so it allows for the needle to get inserted during dialysis. And sometimes over time, you get enough scar tissue where you might have to get another fistula placed because the original one might, not work as well anymore. So what do you see with chronic kidney disease? Decreased GFR. That's the major thing. And then, of course, azotemia. What was your question?
Oh, no, I was just going to note that it looks like they just made a portable hemodialysis machine.
They did what?
They just made a portable hemodialysis machine.
Yeah.
They're putting through clinical testing. I was trying to find a paper on it.
They have, there's someone I was talking to the other day who said that one of their relatives is going to get like at-home dialysis.
So it's like this year they're like hoping to have it.
Yeah, it's amazing. It's absolutely amazing. What they really need to do is develop a artificial kidney that can be surgically implanted, and I don't know why they haven't done that yet. There's like lots of research still being done on this, but I think it was this year where they had the first pig kidney that was implanted on a patient. It was the longest that a animal organ ever was accepted in a person's body without graft rejection. This was earlier this semester in September, and that's the last I heard of it. I tried to look into it to see if it still held, because I haven't heard if it got rejected yet. But the last time I checked, it was like a month and a half, and that was the longest an animal organ was ever successfully implanted in a human. So I don't know, hopefully within the next 5 years, maybe 10 years, we're going to get something that's beyond dialysis, because dialysis sucks. You're hooked to a machine for 4 hours, 3 days a week. That's a long time. That's a lot of your time just being drained away. And then again, it's very exhausting. So these are all the things that you'll see as well with severe CKD, so anemia, right? Because you're not getting production of erythropoietin. You're also going to get hyperkalemia because remember, when you're excreting sodium, when you're reabsorbing sodium, you're going to be excreting potassium. If that's not all working, you're going to start seeing elevations of potassium within your blood, hypertension, edema, low albumin levels, and dyslipidemia. So not fun. So what are some of the major complications? So you're retaining sodium, you're retaining water, you're retaining potassium. Okay? This is one of the reasons why a person who's retaining lots of water, they can't drink much water anymore. They have to reduce their fluid intake, so they have to do ice chips. That's one of the major things. They're also going to have acidosis because of the electrolyte imbalances, as well as uremia, right? You're going to get uremic because of this. You're also going to see proteins being affected. With this, you get hyperlipidemia. That's another complication. Cardiovascular disease because of hypertension, right? You get reduction in EPO causing anemia. And then we just talked about vitamin D as well, calcitriol. If you have reduced calcitriol, remember we talked about secondary hyperparathyroidism. This is a great example of that, right? If the kidneys aren't producing or able to convert active vitamin D, then you're not going to get as much calcium in your diet, then your parathyroid glands come into play. So you get secondary hyperparathyroidism, secondary to the kidney failure and kidney damage. And then eventually over time, that can start causing osteoporosis, right? Because with PTH being released, you're going to get osteoclast activation. Osteoclasts crush the bone down, release calcium, and you're eventually going to develop osteoporosis. Metabolic acidosis, not always, but when it comes to kidneys, you can associate hydrogen protons with potassium as well, right? Because they're going to kind of go hand in hand. So if you have increased potassium, you're also potentially going to see increased hydrogen. You're going to see acidosis as a consequence. How do you treat this? One thing you could do is block the renin-angiotensin-aldosterone system. One of the common drugs you can see are ACE inhibitors. ACE inhibitors help to reduce blood pressure. You can use ACE inhibitors for hypertension too. But ACE inhibitors like lisinopril, captopril, those drugs block ACE, block the conversion of angiotensin 1 into angiotensin 2. Okay, so that's the major thing. You can also do angiotensin receptor blockers. Those are referred to as ARBs. But if you're blocking this whole process, you're going to see hyperkalemia even more. Right? You're blocking the release of aldosterone with all this. And aldosterone exchanges sodium for potassium. Remember, you're bringing on sodium in exchange for potassium. If you block the RAS system, you're blocking aldosterone at the end. So you're not going to be exchanging sodium for potassium more. So potassium levels are going to increase. So you become hyperkalemic. What's your EKG going to look like? Spiked T waves. Yeah, so you'll see spiked T waves with that. All right, any questions on chronic kidney disease, CKD? Okay, let's finish up with Wilms tumor. Wilms tumors are pretty rare. It's a mixed tumor, and it's usually going to happen in kids. Chromosome 11 is the major one. There's a couple genes involved, WT1 and WT2. What do you see in terms of signs and symptoms? A upper abdominal mass. So that's going to be an asymptomatic upper abdominal mass. Generally, it's going to be felt by the parent. The parent is the one that feels this during bathing especially. What's going to happen? You're going to see hypertension in this patient. The tumor is going to secrete lots of renin. And renin increases your blood volume, increases your blood pressure. So that's why it causes hypertension. This is super rare. I didn't see this directly, but I saw this indirectly when I was doing pediatrics out in London. There was this one parent that she felt the mass in the child, took her to the hospital. I was like, oh, it sounds like a Wilms tumor. So this is like the one and only time I ever heard of that in a patient. This is like super rare. So not very common, but there's some other things that can happen with Wilms tumors. You can get other things being affected. So You can have muscle issues, so you can get hypertrophy in one side of the body. You can also see the eyes being affected, so you can get aniridia, which is you don't have an iris anymore. That's because the gene in chromosome 11 is being affected. Yeah, so those are other things that you might see, not just the hypertension, not just the renin, but you can also see other things being affected. You want to do an ultrasound or a CT or an MRI in that patient, and then treatment, you can do surgery with radiation as well, because it is a tumor. All right, we have 10 minutes left. Do you have any questions? We can do some quizzes questions. All right, let's do some quizzes questions, and then we'll call it a day. Doing good, man. How are you doing? Yeah.
I'm sure you are.
Oh yeah. Yeah, I'm so excited for next week. Yeah, sure. Let's get to see you, man. Take care. No. We're also going to do some reproductive issues. We're going to talk about repro on Friday. So it's renal, repro, genetics. So you guys did all the genetic stuff on your own, right? Yes, over Thanksgiving break? Good. The genetics disorders are pretty straightforward, so. All right, let's go ahead and begin. So this guy has BPH, benign prostatic hyperplasia. He also has a fever, right? So as soon as you see fever, the guy has a history of BPH, you're thinking UTI. And 100% of you guys got that question correct, so I'm going to stop talking and move on. All right, looks like we're kind of split on this question here. So some of you thought urinary incontinence. Some of you guys correctly said interstitial cystitis. Why did you think urinary incontinence? Okay. There's one thing that might throw some of you off here is once you urinate, it's temporarily relieved, right? So this means this person doesn't have a Hunter's ulcer. The Hunter's ulcer, remember the Hunter's ulcer is like really severe interstitial cystitis. If she had a Hunter's ulcer, that would probably make it worse. Voiding, right? So releasing releasing all the urine, and then now the Hunter's ulcers can come into contact with the other parts of the bladder. Yes?
How would a cystoscopy reveal?
You could see it. That's a good question. Yeah. If it was urinary incontinence, a cystoscopy could see if the person, if this was a guy, an older guy especially, maybe the person has BPH or something, you could see that in a cystoscopy. But that's a great point. Yeah, you wouldn't really, for this lady, you wouldn't want to give her a cystoscopy if she had urinary incontinence. You only really want to do that if she had something more severe like cystitis, bladder cancer, and things like that. All right, so this guy has benign prostatic hyperplasia. The examination, you do a digital rectal exam that's also referred to as a DRE. So it's a common thing that you do, especially in like primary care. So that's a fun time. If you notice a firm mass, that's going to cause, likely it's going to cause incontinence. So most of you guys got it correctly here: overflow incontinence. Not necessarily urge incontinence. This is overflow incontinence. Stress incontinence you would see more with, contraction of the detrusor muscle, or maybe the person was pregnant, things like that. So this is overflow incontinence, when you have blockage of the urethra because of BPH. Good. Yeah, this is nephrolithiasis. So on a CT scan, you see a 5 millimeter calculus obstructing the ureter. So that is nephrolithiasis. Yes. Colicky, it's just like a type of pain. It's like, let me pull up a good description. I'm going to have a hard time describing that for you. So, colicky. So it's usually intestinal. It's going to be an intestinal type of pain. You see this with like little babies. You say like a colicky baby, right? So you get like intestinal pain. Comes and goes, intensifies and eases. So that's basically what a colicky type of pain is. Okay. This is definitely not glomerulonephritis. This is a kidney stone, so nephrolithiasis. Let's do one more before we head out. And then I urge you to do the rest of these on your own. So softball question, right? Calcium oxalate. That's going to be the most common type of renal stone. All right, any questions about today? Cool. So at some point, not tonight, but like maybe tomorrow, I'll be posting the slides for sexual reproduction, and then we'll cover that on Friday. And I'll try to put together a high yield review so we can go through everything we learned all this semester. Fun. All right, take care, guys. Have a good one.